Can everyone hear me okay? Perfect. Good afternoon, everyone. Thank you so much to the program host and to the chair for having me here today. Thanks for sticking through with me. I think I have the popular last slot before a networking fun event, so I'll try to be efficient. So I am Katy Tsai. I am a melanoma medical oncologist at UCSF. I wear one hat as a clinical researcher involved in therapeutic drug trials for our immune refractory patients. And I also wear another hat as co-director for the SITE program, or our Cancer Immunotherapy Toxicity Evaluation program. So I'll be putting on mostly that hat today for this particular talk, Managing Immune-Related Adverse Events in Cancer Treatment. These are my disclosures. And so for the next 20 minutes, even though it might seem a little bit self-evident, for the purposes of this particular talk, I did want to put immunotherapy and immune-related adverse events into context, so I'll spend some slides there. I will touch on general management principles for immune-related adverse events, but I thought that for today, given the time allotment, that I'd do something a little bit different, and after these general principles, dive into a case presentation. Admittedly, that does limit to one specific IRAE or immune-related adverse event, but I thought that that case might be helpful in illustrating some larger principles of where I see this field moving in general. After that, we'll wrap up with some future directions and thinking about what resources exist for all of us, both in our backyard and also on a larger scale. So jumping into things, all of us who treat patients are well aware that the word immunotherapy is very broad and includes a lot of different kinds of drugs. Broadly speaking, immunotherapy, of course, refers to cancer-related treatment that helps to augment the anti-tumor immune response, and that can include non-specific or non-targeted therapies such as interferons, interleukins, etc. Specific or more targeted immunotherapy can include a number of things, as you can see on the right side of this table. I think that the field of adoptive cell therapy, specifically in solid tumors, is really exciting and changing a lot. But for the purpose of this talk, I will be focusing on the immune checkpoint inhibitors, since these have now formed over the past decade or so the backbone of treatment for so many different cancer types. Immune checkpoint inhibitors, or ICIs, are so named, as we know, because they block certain pathways that contribute to the inhibition of active T-cell immune surveillance of tumors. As you can see on this cartoon on the left-hand side of the screen, there are multiple co-stimulatory and inhibitory interactions that mediate the interplay between our immune cells and our tumor cells. The PD-1 antibodies are a foundational example of how blocking an inhibitory pathway, specifically the PD-1 receptor on the T cell between its ligands, PD-L1 or PD-L2 on tumor cells or other tissues, can potentiate T cell activity. Here on the right-hand side of this table, if this looks busy and unreadable, that's kind of by design. This is a non-exhaustive list of indications for the 13 immune checkpoint inhibitors that are currently FDA approved. As someone involved in the treatment of melanoma and skin cancers, I have bolded the one that I frequently use in my practice, which, as you can see, is the majority of them. But I think really the takeaway message here is that for these 13 ICIs, there are over 100 FDA-approved indications for these drugs. So really hard for any one person to keep track of. And then the trends that we're seeing more recently are, number one, that these are increasingly used in combination, and also in earlier and earlier stages of disease, so in the adjuvant and in neoadjuvant settings for several different cancers now. So with such a success story comes obviously some downsides, and specifically for ICIs, the cost is this myriad of possible IRAEs. For those of us that treat patients, of course, this comes at no surprise that any organ system can be at risk. The range of presentation is very varied, from acute and fulminant to chronic and indolent. And I think really this poses a number of questions. Number one, how severe can IRAEs be? So on the left-hand side of the screen here, you can see the CT-CAE grading, which codifies severity of these adverse events. The grading can differ depending on which particular sign or symptom we're talking about. But overall, you can see that grade 1 refers to a mild event, all the way up to grade 3, 4, and 5, which is more serious, life-threatening, or potentially even death. How often do IREs happen? We try to get the answer to that question if you refer to the table on the right-hand side. So this was a meta-analysis. This was pooled estimates of, I think, over 30 randomized controlled trials, and over 16,000 patients were included in this particular analysis. So I'll point out kind of the relevant things here, which are that with PD-1 monotherapy, a serious or grade 3 to 4 IRAE is not very common, right, approaching 15%, but that when we start to combine immunotherapies or immunotherapies with other categories of drugs such as chemo, that pushes it up to closer to 50% or even over 50%. Also sobering and important to realize is that the risk of death is present. The numbers are thankfully small, less than or about 0.5% with PD-1 monotherapy, just over 1% with anti-CTLA-4 or other ICI combinations. But keeping in mind again that ICIs are increasingly common, very large numbers of patients are being treated with these, definitely want to do our best to continue to push the envelope in terms of IRE recognition, IRE prevention, and treatment. Other questions that come up, how do they happen? So in general, right, excessive immunity against normal organs. Unfortunately, this can happen not only against your tumor tissue, but against normal organs. I think the mechanisms are varied. For example, there may be similar T cell clones in the tumor versus in normal organs. That's been shown in myocarditis. Also thinking about vitiligo or anti-melanocyte protein recognition in our melanoma patients, for example. Is it possible that PD-1 blockade can modulate humoral immunity as well as T cell mediated immunity? In other words, for something like thyroiditis, is it possible that there's some enhancement of pre-existing anti-thyroid antibodies in the body? Elevated cytokine levels in colitis models. So ultimately, I think there's not just one answer here, and that the mechanism of toxicity likely does vary depending on what organ system is affected. When do IREs happen? So thinking about that question is what I've tried to illustrate here. So here, the graphs you can see here are pooled analyses over 23 trials. Patients treated with either nivo monotherapy, ipi monotherapy, or a combination thereof. So in charts A through C, you can see that the beginning and end of each curve represents the median time to IRAE onset and resolution, respectively. And going on the theme we saw in the earlier table, you can see that patients treated with a combination of nivo plus ipi definitely have higher frequency of side effects compared to those treated with monotherapy compared to the graphs above. And then also important to see beyond the peak of the curves here is also the tail on the curve. So you can see here that across all three charts, not all IRAEs resolve. Looking at the colors here, so in general, we're looking at endocrine side effects, and skin side effects are the majority of the IRAEs we see that can become chronic. So also important to realize that, unfortunately, some of the side effects that happen with this category of drugs can indeed be permanent, or maybe the more optimistic way of framing that is that it can be waxing and waning and be a chronic illness that thankfully is treatable, but which requires long-term management. So this is kind of getting to that point here that as we increase survivorship for our patients, I think that this puts increased recognition of chronic IREs, that this brings this issue into the forefront. The study looking at patients treated in the US and Australia was published, I think, recently, a couple of years ago, and actually recently updated at ASCO. But basically what they showed is that in patients receiving adjuvant PD-1 monotherapy, that of these approximately 300 patients, that 46% of these patients went on to develop chronic IRAEs. And also importantly, that 53% of those who developed acute IRAEs then went on to actually have a more chronic indolent manifestation of their particular sign or symptom. Not surprisingly, the majority of these chronic IRAEs were endocrinopathies, but at the same time, also important to realize that non-endocrinopathies can also become chronic. Specifically, the most common or the most frequent ones that were seen in this particular 300 patient group, the most common among them were arthritis, arthralgias, and also dermatitis and or pruritus. But there's kind of a smattering of other potential side effects, as you can see here. Xerostomia, hepatitis, neuropathy, the list goes on. So in terms of general management guidelines, again, I've highlighted here the excellent professional society papers that you can reference on your own time, but I've kind of adapted the SITC guidelines into tabular format here and added my own color in italics. So I think in general, yes, for a grade 1 or mild IRAE, it is reasonable to continue ICI treatment with close monitoring and consideration for some symptomatic support. For a moderate IRAE, I think most would probably think about holding treatment. Corticosteroid can be administered, a low to intermediate dose. And in general, I would say that immunotherapy probably could resume once the IRAE in question reverts to grade 1 or less, and that patient is requiring an equivalent of prednisone 10 milligrams or less per day. For grade 3 or 4 IRAEs, so these are more severe, the patient is probably in the hospital or close to it. So in general, yes, holding immunotherapy is probably the right thing to do. Starting corticosteroid at a dose of at an intermediate to high dose probably also is warranted, and as long as there is improvement, then proceeding to taper over at least 4 weeks. I think that a lot of the society guidelines have some language along the lines of if there's no improvement or worsening within 3 days to consider starting something else. I think in my practice, anecdotally, I will be, I think within 2 to 3 days, so aiming towards the shorter end of that if there is no improvement, to do something, right? Either increase a dose of steroid if that seems like it would be clinically useful, or adding on a selective immunosuppressant also can be of use here. I think a lot of guidelines also will generally state that for a severe IRAE to permanently discontinue said treatment. I think in my experience, really, this is a multidisciplinary conversation between the treating oncologist and the subspecialist. I do think that depending on the disease type, the anticipated benefit, and the potential for a flare of said IRAE, that obviously risk adjusted, but I wouldn't necessarily rule out ICI rechallenge in that setting, especially if there may not be other rational treatment options available. So that's kind of the general schematic of things, and maybe just to illustrate that in practice, I wanted to bring up this case of a 48-year-old man with advanced stage 3 melanoma who received neoadjuvant ipi-nivo, so combination immunotherapy. After 2 doses, he calls up your clinic and says that he has diarrhea. What do you do? So I think a lot of us would probably want some more detail, right? So some key questions to think about would be the frequency of the bowel movements, the consistency of the bowel movements, also trying to sort out, diarrhea versus colitis. Are there any red flag symptoms such as blood in the stool, fever, severe abdominal pain? And for patients that sometimes can have difficulty elucidating that on their own, a visual, i.e. the Bristol stool chart, often can come in handy. So A lot of things can cause diarrhea, but obviously in someone who got ipi-nivo, I think immune-mediated diarrhea or colitis should be top of mind here. So just a reminder here that diarrhea is the second most common IRAE in patients receiving ipi-nivo after cutaneous side effects, and is in fact the most common gastrointestinal IRAE. And a reminder that this is just kind of in bar graph format, a list of IRAEs which can be fatal. Diarrhea, unfortunately, left to its own devices, if it's not managed properly, can be life-threatening. In terms of CTCAE grading, so this is, you can reference this in the guidelines as well, but just a reminder here that the CTCAE codifies severity of diarrhea based on the number of bowel movements above baseline that someone is having. And that the treatment regimens really are based on grading, also potentially endoscopic findings if available, and of course the treating physician's expertise. And here's an example of a stepwise rubric for escalating, for management of diarrhea or colitis based on escalating immunosuppressive therapy. In terms of evaluation, so I think these are general things that I would consider things that definitely should be done in terms of non-invasive workup. In terms of serologic workup, definitely doing the basics, electrolytes, CBC, pancreatic enzymes, and liver function tests, thinking about ruling out celiac disease, especially if there is a clue about dietary triggers. In terms of stool studies, fecal calprotectin, so this is a calcium binding protein that is derived from white blood cells and correlates with the GI inflammation. This has been a useful way of quantifying the amount of GI mucosal inflammation that can be tracked over time. And certainly also checking for pancreatic insufficiency via fecal elastase, and doing due diligence with infectious workup is of course important as well. Imaging can be incredibly useful to rule out other potential etiologies for these symptoms. And of course, calling your friend, your friendly GI consultant early can be helpful with an eye towards trying to get that patient in for a more invasive or an endoscopic procedure. So this particular patient received oral prednisone, 1 milligram per kilogram, did not do well. Ongoing nausea and diarrhea, and ended up being hospitalized with grade 4 colitis. And endoscopy was done with GI well inpatient, and because there was little improvement with 2 days of IV steroid, the patient went on to receive an anti-TNF alpha, infliximab, on day 3. Thankfully, there was subsequent improvement, and the patient was successfully discharged on a PO steroid taper and was doing much better by second week. Over on the right-hand side, you can see the colonoscopy, or in this case, the FLEX-SIG photos showing erythema, large, deep ulcers in the colon, and on pathology, the presence of crypt abscesses and epithelial apoptosis. Here, I would say just a note that endoscopic evaluation obviously preferred, but I know not always possible. Logistically, from talking to our team, I know that a full colonoscopy, while preferred, sometimes is not necessary. Flexible sigmoidoscopy has the advantage of being faster and requiring a less complete prep. And I know that on the GI end is also time-wise sometimes easier for them to schedule. A few of you may be wondering, why did this patient get infliximab versus vedolizumab? Vedolizumab is an anti-integrin that limits white blood cell trafficking into the luminal GI system. So our good colleagues over at MD Anderson did or are still conducting this head-to-head trial of infliximab versus vedolizumab for immune-mediated colitis. I think relevant things here I would say are that it does seem that infliximab seems to work a little bit faster compared to vedolizumab, but that overall in the longer term, that the patients who received vedolizumab seem to have more benefit in terms of a shorter steroid taper, and in the longer term, fewer hospitalizations and a lower recurrence rate. In my practice, I would consider both as good options. Certainly for someone who's inpatient or in more immediate need of life-saving treatment, I think you could make a case for infliximab. Honestly, sometimes, unfortunately, it does come down to a little bit of what insurance will approve as well. I think that there's little downside to implementing this early. There is data that when we start selective immunosuppressive therapy earlier, that it actually does help to improve patient outcomes, specifically the duration of the symptoms, the number of hospitalizations that will be required, and also the length of the steroid taper. So here you can see the data for starting a selective immunosuppressant, either less than 10 days out versus more than 10 days out, with clear benefit for earlier intervention. It's an interesting world out there. So I think when I was in training, certainly, maybe that was the limits of what we could do, is repeating steroid tapers and a lot of infliximab. Taking a page from the inflammatory bowel disease world, what I've learned from my GI colleagues is that there are other selective immunosuppressive therapy options now too. JAK inhibitors, tofacitinib, upadacitinib have been good options. There is some small case series level and anecdotal data out there attesting to the efficacy of this in a steroid and infliximab, vedolizumab refractory population. Also taking a page from drugs approved for other things such as psoriasis, rheumatoid arthritis, anti-IL-12, anti-IL-23 agents also have shown efficacy in these refractory patients as well. Here on the upper right-hand side, this is some work done from our group in collaboration with GI, showing that a patient who received risankizumab actually for her psoriasis, we were able to get insurance approval for that for treatment of her immune-mediated diarrhea. And these are ultrasound images from top to bottom showing, hopefully you can appreciate really a lot of bowel edema here, which is now decreased. And same thing in the terminal ileum, pre-risankizumab and then post-risankizumab. On the bottom here, this is data from MD Anderson, and I know it's a little bit small and hard to read, but basically this is grade of diarrhea on the y-axis and time on the x-axis. And this patient, you can see, received a lot of things, vedolizumab, steroids, hospital stays, and it wasn't until they got ustekinumab, which is an anti-IL-12, 23, that the grade of the diarrhea went way down here. And this is demonstrating basically the same pattern, but with the addition of ustekinumab here as well, with decreased diarrhea grade. There are other investigational options out there, specifically FMT or fecal microbiota transplantation, also anti-IL-6 receptor. I think the tocilizumab or anti-IL-6 receptor antibodies should be used with a bit of caution. There is the potential for GI perforation, and so sometimes in our colitis patients, again, could be considered, maybe off-label, but probably not the first thing that I would reach for. So in terms of future directions, just maybe continuing the note about anti-IL-6 data. So certainly I recently presented at ASCO this year. There was a trial looking at IL-6 as a rational approach to improve clinical outcomes, both in terms of tumor response and for IRAE prophylaxis. This seems like a rational target because IL-6 has been shown to play an important role in mediating the interplay between Th17 and IL-23 and IL-1 beta, which are triggers for inflammation and autoimmunity. So this seems like a rational target. I'm going to speed along here, but I just wanted to show you the study design here where they utilized triple, so this is for melanoma patients. This is triple immune checkpoint inhibition with IPI, Nivo, plus relatlimab, so anti-CTLA-4, anti-PD-1, anti-LAG-3, expecting a whole host of toxicities. And sarilumab, which is a newer IL-6 agent, was given every 2 weeks subcutaneously for the first 16 weeks. To cut to the chase, you can see here that, did this achieve the primary endpoint of reducing IRAEs? The answer is yes. So you can see here that the overall severe grade 3 to 4 IRAE frequency is 12.1%. If you recall the table I showed you earlier, and the authors kindly remind us here that this is the rate of severe IRAEs with other combination immunotherapies, we're looking at from anywhere from 12 to 43% down to 12.1%. So certainly food for thought. and that this seemed to be feasible without compromising anti-tumor efficacy. So you can see here the objective response rate of 63.6%, which is comparable to other landmark trials in our field. So again, single-arm trial, relatively small numbers, but certainly food for thought in terms of what we could accomplish in the future. So I know that I'm over time, but I did want to touch briefly on things I can leave you with that might actually be helpful in your day-to-day. So number one, at least here at UCSF, and this is an open resource for all of you and all of your patients if you choose to take advantage of this. Here at UCSF, similar to other institutions, including Stanford, which I know has a bit of a different model, but something similar, is our cancer immunotherapy toxicity evaluation program. This is co-directed by myself and Dave O, and is NP-led by our wonderful nurse practitioner, Emily Pepe. And you can see here kind of our three vision statements or goals since our program was created 2.5 years ago. This was meant to address disparate access to subspecialty care, not only within the community, but also within our own institution. And because a lot of this treatment is driven by expert consensus opinion, we really wanted a forum. We meet every 2 weeks as a multidisciplinary tumor board. We just wanted to create the infrastructure and put the right people in place to be able to improve across the board IRAE care for our patients. This is the way that our program works. You can refer directly to us, either from UCSF inpatient or outpatient, also from the community. Patients are able to self-refer as well. And if you have questions, certainly feel free to come up to me afterwards, visit our website, scan the QR code. I'm happy to be of help if we can be. Last but not least, I'll put in a plug for Aspire. So for those of you who may not be aware, the people who founded Aspire, which is kind of this national network alliance for support and prevention of immune-related adverse events. This was founded by one of my colleagues, Dr. Funchin at Stanford, together with colleagues at the MGH and other institutions. If you log into the ASCO My Connection webpage, this is now a formal community of practice as of 2025. So if you log in and create an account for yourself, that does allow you access to certain resources, notification about events, which can be helpful in IRAE care. I wanted to highlight some upcoming virtual events that you may be interested in. Certainly this information is available on the ASCO My Connection website for those of you who would like more detail. So these are my takeaway points. Number one, IRAEs can range from acute to chronic. Definitely we expect more frequency and severity with combinations rather than monotherapy. Secondly, corticosteroids can play an incredibly important role, but don't let them linger. There is a movement towards earlier steroid-sparing strategies, not only in colitis, but I think across the board with other organ systems affected by IRAEs as well. Thirdly, I would make a plug for having the conversation with your subspecialist, with the patient, about the risk versus anticipated benefit of re-challenging IRAEs, whether that's safe and appropriate. And last but not least, phone a friend, right? I think that even as oncologists, a lot of what we do is increasingly driven by what we borrow and learn from our subspecialty colleagues and treatment of inflammatory events within their organ system. So always happy to help or direct you towards the right person. If not within UCSF or another academic institution, certainly asking those same questions within your own practice, right? Is there someone I can refer to, someone who has an interest in seeing these, who is willing to talk over management with me to improve care for the patients? So, sorry to go over, but that is the end of my talk. I wanted to thank everyone for staying till the end and happy to stick around for more questions.
Thank you. I think we'll go ahead and wrap up, but if you have any questions,